Good evening, fellow classmates and faculty. My name is Devin Bentley, and I'm here today to share my scholarly project with you all. I do apologize ahead of time. I am feeling a little under the weather. But before I begin, I would like to just take some time to acknowledge a couple of people. I do want to thank my chair, Dr. Wonderlook, for her guidance and support throughout the entire program. I could not have done this without her. I would also like to thank my family for their patience, understanding, and support because this has been tedious and taken a lot to complete. And this project is for Jalen, a soul lost too soon. So the name of my scholarly project is Self-Management of Asthma, a Quality Improvement Project. My project is very near and dear to my heart. On a spring night in 2017, my 9-year-old cousin was playing with his cousins at his grandmother's home. He started to have some wheezing and he felt short of breath. He did have history of asthma, but no one really paid attention to the symptoms he was experiencing and didn't know that the things would get so severe. So about an hour later, one of the other kids ran into the room to let the grandmother know that Jalen was lying on the floor. And at that time, he was unresponsive. And unfortunately, the family didn't recognize that he was in distress, so his asthma action plan was never activated, and he died before he made it to the hospital. And I pretty much did this project because of him. So in introduction, pediatric deaths, extensive hospital stays, acute care visits, and missed days from school due to asthma are preventable in the pediatric patient when they have the tools to self-manage their symptoms. And then I'm going to go into my PICO statement, the purpose and the aims. So my PICO question: what is the effect of an educational program on the self-management of asthma in the school-age pediatric population as compared to no education on self-management of asthma on the rate of acute care clinical visits? The purpose and aims. The purpose of the scholarly project is to develop a quality improvement project to improve the self-management of asthma in the school-age pediatric patient to address this challenge. The aim is to determine if the implementation of this quality improvement project will actually decrease the rate of acute care clinic visits. The overall goal is to decrease the incidence of patients experiencing asthma exacerbations by improving their ability to self-manage their symptoms and disease process, thus improving patient outcomes. So an integrated literature review was conducted and 3 themes emerged from the analysis. Those themes included self-management of asthma, interventions, and education empowering patients. The self-management of asthma. The amount of evidence in favor of asthma self-management is overpowering. Increased asthma education and written self-management plans are associated with better asthma management in pediatric patients. Supported self-management has shown to be effective and is easily and quickly delivered in several settings and populations. So a review of this extensive evidence-based practice concluded that asthma self-management supported by regular follow-up improves asthma control, it reduces acute care visits, exacerbations, and admissions, and it improves the quality of life. A lack of the self-management skill set is known to contribute to poorer outcomes and worse adherence to clinical asthma guidelines. Then we have our interventions to self-manage asthma. Learning how to effectively manage asthma as a chronic disease is a significant challenge for people with asthma and their families. So in efforts to address this challenge, various methodologies have been created and executed in multiple settings, including clinics, hospitals, homes, and schools. Key intervention components to improve asthma outcomes identified included the provision of asthma information and self-care education, asthma action plans, self-monitoring, feedback from devices, messages and alerts to patients, things like games and quizzes, and availability for daily use. And one of the other crucial elements of effective self-management was the provision of an agreed written action plan. Excuse me. A written action plan, or the asthma action plan, is a personalized written document that leads you in the correct direction by giving a set of steps to keep your asthma from worsening. It also guides when to call your healthcare provider or when to go to the emergency room. This is a vital tool to share with caregivers of children with asthma, including daycare providers, schools, and aftercare programs. I do have a copy of an asthma action plan on a later slide, so we can view. Excuse me. Education in empowering patients. The National Heart, Lung, and Blood Institute developed clinical practice guidelines to emphasize formal and comprehensive asthma self-management education as a key piece of optimal asthma care. Patients and families play a vital role in decreasing the burden of asthma. They can affect change by reducing exposure to environmental triggers, adhere to medication regimen, careful medication management, and responding quickly to exacerbations. Next, we have asthma education. So education alone does not consistently improve patient or clinical outcomes. Asthma education and information should be available in different formats, from electronic formats such as videos or written information online, paper formats such as handouts or pamphlets. Patients should also be given the information and guided to the acceptable sites that offer resources and information from national patient organizations and health services. Several factors should also be considered when planning how to deliver asthma education, like health literacy, the age, communication barriers, cultural influences on health beliefs, access to care, any psychosocial issues, education method and the setting. Teaching asthma self-management to pediatrics, it has to involve the parents, and the child should be included as much as possible and learn how to recognize the symptoms and seek care. So we already talked about parent and family involvement, and we also talked about the written action plan, and we will go more in depth on another slide with that as well. Methods. Okay. So the methodology was a non-experimental, retrospective, quantitative, descriptive study. It was after a 2-month trial period from March 1st of 2021 through April 30th, 2021, a retrospective electronic medical record review was conducted. And this was done 3 months post-intervention. This gave the participants enough time to return to the clinic for an appointment for exacerbation or for a hospital visit. And then the minimum necessary data to accomplish the goals of the project was collected on the data collection sheet, and all patient identifiers were removed. So I said we were going to get back into the asthma action plan. Here is a copy of the asthma action plan, and as you can see, there's one for home and school, and it's 2 different forms. Excuse me. So with the project, an educational intervention was presented to the nurses, providers, and the corpsmen, and they were presented with the current asthma practice guidelines and the asthma action plan. So for the asthma action plan, these include the specific names of asthma medication, the different asthma triggers, peak flow requirements, symptoms that would indicate poor asthma control, and any medicines to take at the appropriate time based on either the peak flow measurements or the signs and symptoms and emergency contact information. And then, as you can see, the asthma action plan is divided into 3 zones: the green, yellow, and the red. So the green zone signifies no asthma symptoms. The yellow zone is where the patient begins to experience some symptoms, and the plan guides the patient through the correct steps to follow to improve those symptoms. The red zone signifies severe asthma symptoms, and the patient should follow the steps and get emergency help if the symptoms don't improve. So an asthma action plan facilitates the early detection and treatment of an asthma exacerbation and is an essential part of the effective self-management of asthma. The data collection sheet. This is the sheet that was used to obtain the patient information. So on this sheet, it includes if the patient came in for an acute visit within the 3 months post-intervention, and if the patient had been hospitalized, and the information is depicted by either a 1 for yes or a 2 for no. It also, states whether the patient received the educational intervention or not, and that's also 1 for yes and 2 for no. There was extra information collected, and it included if the patient received the influenza vaccine and the pneumococcal vaccine. And then this information was depicted by a 1 for yes, a 2 for no, or a 3 for if the patient or parent refused, and 4 if they were unable to administer the vaccine due to a medical condition. So the results in the analysis. Quantitative methods. The research technique adopted for this study favored using large randomly generated samples. A nominal scale was used to document whether the educational intervention was performed verbally, and if the patient received the educational pamphlet, My Asthma Action Plan. And we already talked about the numbers on the data collection sheet that represented that. Additionally, the EMR was used to document the influenza vaccine and pneumococcal conjugate vaccine. And we talked about that as well. A z-test for the difference of 2 portions was performed to determine if the rate of those educated was less than the rate of those that did not receive the education, compared to one rate of acute clinical visits or hospitalizations to the other. The analytic methods. So again, a retrospective EMR review was conducted, and this was done 3 months post-intervention. It started on August 1st of 2021, and this 3-month wait allowed time for the patient to come in to be seen for an asthma exacerbation at an acute care visit or hospitalization after the intervention was provided. A retrospective chart review of the EMRs was utilized to collect data. The data was generated from those electronic records. The EMRs reviewed were of pediatric patients ages 5 to 17. These patients were seen at the clinic with the diagnosis of asthma from March 1st, 2021 through April 30th, 2021. And a sequential inclusion and exclusion process continued until the written patient list had been reviewed. And then the outcome of the intervention. I will show you some visuals for that. So table 1. Table 1 is an overview of the output. There is sufficient information to suggest a decrease in the ratio from educated to non-educated patients and related to acute care clinic visits. The study analysis was conducted based on the patients and families who were educated verbally and given the educational pamphlet, My Asthma Action Plan, and whether they were seen 3 months post-intervention for an acute care visit or hospitalized related to an exacerbation of asthma. Comparisons were then conducted between these patients and the non-educated patient and families, and whether the patient was seen for the same reasons. A z-test for the difference of two proportions was performed, and the p-value of 0.0086 is less than the significance level of 0.05. There's sufficient information to suggest a decrease in the ratio from educated to non-educated. The difference of two proportions also showed the achieved power of the study is 0.778, which is considered high in strength. The confidence level is 95%, Z equals negative 1.9600, with the interval lower limit equal to negative 0.4389, and the upper limit negative 0.0505. So with this, the confident interval suggests the true change in ratio from educated to non-educated. And since 0 is not included with the interval, there's significant evidence to show change. I also provided this figure. This is just a visual of educated versus non-educated in their acute care visits. And as you can see, the non-educated patients did come in for more acute care visits versus the educated patients. Discussion. So the purpose of the DMP project was to ascertain if educational intervention provided to providers, registered nurses, and the corpsmen at a primary pediatric care clinic improved the number of acute care visits and symptom management in pediatric patients with asthma. The analysis of collected data identified, appraised, and synthesized evidence to observe the current process to improve the current practice. This study's findings established the importance of providing educational intervention to improve the self-management of asthma skills. The data analysis results elicited after educational intervention completed 3 months post-intervention supports that analogy. Increased asthma education and written self-management plans are associated with better asthma management in pediatric patients. This capstone project's findings established the importance of providing educational intervention to improve the self-management of asthma skills. So some of the implications for practice and future research. With this, the strategy should include a team-based care approach to improve the patient's and family's experience. Current practice guidelines and a written asthma action plan should always be provided, along with enough time to discuss and clarify the action plan. A 1-month follow-up should be conducted if the patient's asthma is poorly controlled or if there's a medication change. Otherwise, the patient should be followed every 3 to 4 months. Every provider and registered nurse should be able to educate the patient consistently using the current practice guidelines. More time should be invested to educate patients and their families, but doing this will also offset the amount of time a patient may be hospitalized or need an acute care visit for asthma exacerbation. There have been several studies conducted that show that self-management can greatly improve a patient's quality of life. Nevertheless, there are still issues when it comes to patients' control of asthma. Further research could focus on different facilitators and barriers that lead to non-compliance, poor asthma control, and adherence to self-management of asthma skills. And we'll also talk about some implications for quality and safety. A lack of self-management skill set is known to contribute to poorer outcomes and worse adherence to clinical asthma guidelines. This study's findings suggest that asthma self-management and a written action plan can improve quality of life and reduce the number of acute care visits. The Quality Improvements Project's outcome can help change the negative outlook of some providers when it comes to using the current practice guidelines. Written materials can be provided to ensure pediatric asthma patients' care follows the current practice guidelines. Several training sessions similar to the session to implement this project should be conducted to train the registered nurses and healthcare providers so that they are confident and consistent when providing care to pediatric asthma patients. Recommendations and conclusion. This quality improvement project used current practice guidelines to improve self-management at a pediatric primary care clinic. Patients and their families can see improvement in their self-management of asthma skills by being educated by providers and registered nurses. A reduction can be seen in acute care visits and hospitalizations by consistently implementing the current practice guidelines. The results of this study was presented to the clinic manager, the providers, and the registered nurses at that primary pediatric care clinic. So now a quarterly training will be conducted to ensure the providers are using the most current practice guidelines. And that concludes my project. I do appreciate the opportunity. I appreciate the guidance throughout this whole process. Thank you for your time. Thank you for listening to my project. Here are the references as well. Thank you so much. That concludes my project. You guys have a great night.